So, welcome back, everybody, to the third part of our series on perinatal mental health. It gives me great pleasure to welcome back Dr. Jenny Barnes, who is a perinatal mental health champion in Warwick. And we've had two really wonderful podcasts before this looking at opening the conversation, looking at the impact on families, and the most recent one, thinking about OCD and some of the more common and more serious aspects of perinatal mental health. And today we're going to be talking about what we might do when we suspect it, when we see a patient with perinatal mental health issues. So welcome back, Jenny.
Thanks very much for having me back, James.
Oh, it's always great to have you. So I think probably we often talk about prevention being better than cure. So what can we do to identify people that might be at risk? And once we've identified that risk, what more can we do?
Absolutely. So I think it's really important to just think, well, can I predict any of the women that I know that they may have problems in the perinatal period? So we've talked a bit in the first podcast about risk factors for people who will have mental health problems in this time. So we talked about the toxic trio, previous mental health problems. So these women and families you will know about. But again, it's probably having the time to review them and to put support in place. Part of it is trying to be a bit more proactive about it. So you may have women of childbearing age on antidepressants. Do you just say to them when you do their medication review, or maybe your pharmacist? Again, this comes back to the conversation we had about educating the whole of primary care about this. Do you say, if you're thinking about getting pregnant, just come and have a discussion with me before that, and we'll have a chat about your antidepressants? Because when we come on to talking about medication at this time, it's so much easier to have a conversation about medication before they get pregnant. So preconceptually, to have that conversation and get some advice if you need it. So just think about when you're seeing people, well, actually, am I worried that they might develop this? And then I guess it comes on to what you said, James, is, well, what do I then do about that? So some of it might just be having that conversation with families just to raise their awareness about it, so that the partners can be aware and let you know if things start happening. They may not do, because sometimes we can't predict who will get a mental health illness. Some women don't have risk factors for it, but families can be aware. So if you notice that X, Y, and Z changes, then please come and let me know and have that conversation. But it may be that if a woman says, actually, I am a bit worried that I might struggle a bit, can you put some other support mechanisms in place? And it'll depend slightly what's around in your local area. But certainly NHS talking therapies. So to have some preconception counselling and support. There may be local charities that can support women locally to you, or you may, dependent on your social prescribing service. When we were doing some of this teaching, actually, we had a social prescriber that came on some of the teaching that I did, and they were then supporting families, which was a brilliant resource. So supporting families, and they then knew what services were available locally.
Yeah, I think the recurring theme comes up that a lot of this takes a whole team approach, which is why it's so nice that there's been this focus on education with yourself and the other perinatal mental health champions, but also taking time. And of course, as GPs, we're very stretched for time. But if we can use the whole team to help support people, pharmacists and medication reviews, social prescribers, and actually utilizing those aspects, it sounds like we can make a really big difference. Uh, the other thing I found quite interesting that picked up there is we talked about risk factors in the first one. We talked about toxic trio and more common in second and third baby, and similarly. But it's quite interesting that some people don't have risk factors, and it would be the first episode of mental health that they have. Um, but that really surprised me.
Yeah, it can be. And I think that surprises women themselves sometimes is, well, why is it happening to me now? Well, it is probably just those, well, it is that massive hormone shifts that are going on. So actually just those hormones are the risk factors themselves for it, and just what is going on in your life as well. So the complete life change and life events that you're going through as well.
Yeah, and lack of sleep, and change in your social life, and change in your sort of place in the world, and change in your relationship, and all of these sort of things that are all hitting you at all at once, really, isn't it?
Absolutely.
Yeah. Okay, so I mean, I think identification really important. Have those conversations, continuity really, really important. So I suppose we've talked a bit about preconception counselling. Are there any particular groups where we need to be particularly on that preconception counselling?
So anyone who has had a severe episode of depression previously or psychosis should be under the perinatal mental health team. So your areas will have local referral guidelines, but that those criteria are fairly universal around the country, that they should be under the perinatal mental health team. So it's just making sure that that actually happens, because that referral needs to just be done, and women may not ask for it. So just being aware of it, or when again you're doing your depression review, saying if you do become pregnant, you really were unwell before, we ought to get you seen by a specialist just to check that everything's okay for you. So it's just planting those seeds, that you're not going into massive detail then, but that hopefully that woman will think, when I get pregnant, actually I just need to tell someone, and it should get picked up at the midwife checks as well. But the other thing that I think is really useful, that's probably underutilized by GPs, is preconception advice from the perinatal mental health team. So the patients may not need to be under them, but they are happy to review women on medication that you might want advice of, well, do I continue this? Is this the safest one for them to use? And to get a plan. And again, that's much easier to do rather than, oh, I'm 8 weeks pregnant. What do I do now? Actually, which again is why just saying to women, if you're thinking about getting pregnant, just come and have a chat with me first, and we can get a bit of advice if we need it. And some perinatal mental health teams have actually got pharmacists working within them, and you can just speak to them about what advice they would give. And some perinatal mental health teams will actually give those women a consultation, and they may just need a one-off consultation. Well, these are your options with this medication, and this is what you need to do. So again, it's just having that conversation and thinking about it.
Yeah, well, but that's really good to hear. I mean, medication is so important, and I reflect on a couple of cases that I've dealt with. You see them at the 8 week check, and they said, "Oh, the moment I found out I was pregnant, I stopped my antidepressant." What is the current guidance around, SSRIs, antidepressants, and on one hand, and I suppose other things like maybe low doses of quetiapine, in other cases, so they may not have had psychosis before. What should we be doing in those cases?
So I think that's what we always worry about as clinicians and prescribers is, oh my goodness, am I going to cause harm prescribing this medication? And quite rightly, we need to reflect on that and think about it. But there is a lot of harm that happens to the baby, to the fetus, with high cortisol levels and mum being unwell. So we are causing harm by not treating and not helping these women on the developing fetus. So there are a few principles that we like to think about when we're prescribing in this period. And one of them is, please don't just knee-jerk stop antidepressants. So if a woman is well and coming and seeing, she's well, she's on a bit of sertraline, which is probably your lowest risk SSRI, and she's well, she wants to continue it, then continue it. We feel that we potentially could be doing some harm by prescribing something, but we forget about the harm that we might be causing if we stop something as well. So I'd encourage people to actually just stop and think. And things don't need to happen instantly either. You have got time to speak to your pharmacist, to look up some information, or to speak to your perinatal mental health team. So please don't just stop antidepressants, is the first thing sort of to say.
Noted. Very sage and and useful advice.
And often it's the woman coming and saying, yeah, what do I do? Should I just stop this now? So don't be led by them, but obviously listen to them. But following on from that, there are a few principles that you can follow as well. So they want to be taking the lowest effective dose of a medication, but it needs to be the lowest effective dose. So there's no point taking something, it's a low dose, but it's not really working, because that defeats the object of taking something as well. If you're going to prescribe something, you want to choose the medication with the lowest risk profile that is going to work for that woman. And that's really hard to work out sometimes,
Certainly,
because
yes.
if you look in the BNF, it normally just says advise avoid in pregnancy or breastfeeding.
Manufacturer advises avoid,
Yeah,
manufacturer can't guarantee. Yes, it's
yeah. And that comes back to the real problem in this period, is that it isn't ethical to do trials on all of this medication. So a lot of it is case study based and experience sort of based about what is safer to prescribe. But there are a few resources that you might want to look at if you haven't already looked at them. So one of them is the UK TIS, is the UK Teratology Information Service, and we'll put a link to it. And it summarises and goes through all the evidence about different medications. And it gives you that evidence that you can look at with women. And they have a patient facing resource called BUMPS, which women can look at as well. And it'll depend on your patient group. But my patients love having, and they want to actually look at the evidence themselves. So some of these conversations are actually going to be giving those women some information and saying, look, have a look at this. I'll have a look at it too. And then let's talk about it again in a few days.
and I think having that honest conversation with patients can be helpful because I mean it's going to be I think part of these conversations is convincing ourselves that we're doing the right thing, and part of it's convincing the patient that we're doing the right thing, and sort of meeting up together. And it's quite vulnerable for us, but saying like, you know, I'm not sure, but I can find out, or let's look at this together. So I love that approach, and I love bumps as well. It's really nicely laid out, and I find myself sending links to patients quite a lot of that.
Yeah, absolutely. I do. Because I think it's really important that women actually understand, because that answer of, well, yeah, it's not safe, or we advise avoid, but actually we need to use it in certain situations. And you're absolutely right. I think it's, as a prescribing clinician, you it's justifying it to yourself that actually this is the safe and the right thing to do as a shared management plan with your patient, and that's what you're trying to achieve, and those resources are there to help support you do that.
Wonderful. Well, I mean, that's really helpful advice prescribing the, you know, thinking that you might be doing harm by not prescribing some cases and using those using the lowest effective dose and making sure we're accessing uh, the right information for ourselves and our patients.
Absolutely. And the other principle that we'd follow is that if you can do, using a single drug is the best way to do it. Now, if you're on more than one drug, I think again they're under the perinatal mental health team. So most women can be supported with medication, probably using a lowest dose SSRI in most situations. But if they have been stable and well on a different antidepressant, and it's taken them time to find that one that works for them, and it may not be your first choice of it, but they are well, then please go with the one that works for them and have a look at it. But a single drug in the lowest effective dose is good prescribing principles.
Oh, excellent, and yeah, and very straightforward advice to follow, because it can feel extremely complicated and quite stressful for us because in this time, which is emotive for a patient, it's emotive for us too. I suppose part of good general practice is understanding and sort of feeling a bit of what your patient is feeling too. So I suppose we've gone through, we thought about before they're diagnosed or thinking about risk stratification. We've looked at during pregnancy as well. So I suppose on the other end, we've identified a patient and we're concerned they've got a postnatal, say, adjustment disorder or postnatal depression. Have you got any advice for us about how we might go about treating that?
So I guess we've talked about the medication side of it, but I would encourage you to think that that is probably a small part of treating these women and families. So really, we're talking about psychological therapies and how we can support them. So NHS talking therapies is the avenue of or provider for that in most areas around the country. And one thing that I wasn't aware of was if you make sure that women or families tell them that they are in that perinatal mental health time, then they will be prioritized. So they will be seen quicker and get the support that they need. And when we've been talking to NHS talking therapies and they've come to some of the training that we've done, they have clinicians specifically with training in this area to support women. And in certain areas, the perinatal mental health teams actually liaise between NHS talking therapies and those patients that sort of overlap in the middle. They'll quite often, move between services to get them the right support. So really thinking about getting some support for these families and psychological talking therapies.
Really, really uh, really useful to know that they'll be prioritized. And I think patients will like to hear that as well. And it's great that we're taking it really seriously. How about for those more sort of severe end? What sort of things might alert us to go, actually, maybe this needs to be escalated?
So I think you'll probably be feeling as a clinician that you're getting a bit out of your depth. There's probably that sort of gut feeling, but they will be on the more severe end of the spectrum. So, and then you're thinking about, do they need a referral to the perinatal mental health team? So if there is any concerns of harm at all, then that should be an urgent on the day I'm speaking to someone with that. If it is getting towards the more severe end of the spectrum, sort of depression, then you may need the support from them as well. And then different areas will have different criteria for the referral into the perinatal mental health team.
Wonderful. And I suppose finally, we have psychological therapy, medications, that kind of escalation. Are there any groups or charities that you might recommend? I'm guessing there'll be locally focused ones, but is there any resource or charity nationally that people might go and explore to help support the patients?
Yeah, so there are lots of really valuable charities and peer support. So there's a lot of peer support going on, and it's in different formats in different areas in the country. But a lot of people who've gone through mental health illnesses themselves then want to support other families with that, which is a really valuable resource. It does vary across the country. There's a good resource called Hearts and Minds, which is a directory of those services. And the charities do support different groups of families as well. So there's some that are for younger women. There are some that support people with domestic abuse and things as well. So sometimes it's just finding what different resources will support that family. Some of them are group sessions, and that can be great for some women, and that gives you the support network. And some of them will be individual support that they can provide as well.
Well, that's really lovely note to finish on. I've enjoyed so much talking and learning more about perinatal mental health and about all of the different aspects that I just didn't know, and I feel so privileged to be updated. And I'm sure our listeners have learned a heck of a lot from you, Jenny. So thank you so much.
Thanks a lot, James, and thank you for giving us the opportunity to record these podcasts, because really that was the aim of this project, is getting the word out there about perinatal mental illness and that we can really help all these women and families. And 90% of perinatal mental illness can be treated in primary care, and we can really make a difference. And it's the bread and butter stuff we do within primary care. So please think about it. And I hope these podcasts have given you some resources and some tips on how to do that better sort of for our families.
Well, absolutely, we have. Thank you so much for talking to us, Jenny. It's been really wonderful learning about this. And I hope that the education projects and updating people and updating our teams in this goes really, really well. It's such an important topic. And thank you for sharing with us your wisdom in this.
Thanks, James.
Okay. Take care. Bye bye.
Bye.